Hello, this is Christina Jensen. I would like to thank you for allowing me to speak today about colon cancer screening updates. No ands, ifs, or buts about colon cancer screening. The objectives that I will cover today include: number one, to understand the importance of colorectal cancer screening. 2, to review major updates to colorectal cancer screening guidelines. 3, to understand the increasing incidence of colorectal cancer in adults under 50. And 4, to understand the difference between Step 1 and Step 2 colorectal cancer screening. So, why do we care? Well, colorectal cancer is the fourth most common cancer in the United States. We see it behind breast cancer, prostate cancer, and lung cancer. Combined in men and women, it is the second leading cause of cancer death. The projections for 2021 by the American Cancer Society show that there will be close to 150,000 new cases of colorectal cancer and 52,980 deaths. The lifetime risk of developing colorectal cancer is 1 in 23 in men and 1 in 25 women. If we look specifically at the state of South Dakota from 2018, we'll see that the incidence and rate of new colon cancer is 38.7 per 100,000 individuals. Deaths are around 15 per 100,000 individuals, behind lung cancer, breast cancer, and prostate cancer. Due to this highly common cancer, in 2000, President Bill Clinton started National Colorectal Cancer Awareness Month. This is in the month of March. This was done to help promote colorectal cancer awareness. It also was developed to advocate for policy change, and in addition, to educate the public about the importance of colorectal cancer screening, early detection, as well as prevention. This is a great slide that will go through some quick facts about colorectal cancer in South Dakota. We can see that colorectal cancer screening test use has actually increased since 2012. In 2016, our numbers show that 65.6% of eligible residents were current with colorectal cancer screening. However, if we look at that number, 87,000 residents are currently not screened. Now, we know screening occurs more frequently in women, people who have insurance, people who are aged 65 to 75, and actually those who were insured by Medicare. If we break it down in South Dakota to ethnicities, 67% of white individuals were screened for colorectal cancer. This is another good informatic with the insurance status. So those who are insured, 62.3% are screened. If you do not have insurance, 40.5% will not undergo colorectal cancer screening. If we look at nationwide trends of the percentage of population screened, we can see for the United States that number is fairly straightforward, with roughly 67.3% of the population being screened in 2016. South Dakota does lag behind a little at 65.6% of the state who are eligible to be screened, as you can see here. This breaks down men and women being screened for colorectal cancer, with 64.1% of women versus 61.3% of men. And then our colorectal cancer screening usage, where we really see the number peak in those individuals in the age group from 65 to 75. But in our 50 to 64-year-olds, only 60.5%. This might be a little more challenging to see, but we're looking for the dark blue, which will show us those individuals with the higher rates of colorectal testing prevalence. So what is the big push, and why did I get asked to speak about colorectal cancer screening? Well, colon cancer can be prevented and not just detected through colonoscopy. So again, detection is important, but prevention is powerful. When we think about colon cancer, we know that the majority of cancers arise from precursor polyps, which have progressed to adenocarcinoma over many years. It's been an evolution from polyp to cancer, and that's a slow process, and really on average requiring about 10 years. Well, why? I mean, why is this happening? We think there's some level of chromosomal instability. It could be due to microsatellite instability or a CpG island methylator phenotype as well. And here is just a great schematic and picture of showing that colorectal cancer development, going from the normal healthy epithelium of the lining of the colon to hyperplasia, the adenomatous polyp, adenocarcinoma, and then even metastatic cancer, and looking over that 10-year time frame. Catching colon cancer early on will give a person a 90% chance of survival, but in that later stage, that survival drops down to 20%. So what do we see when we're doing these colonoscopies? Well, we have the normal healthy appearance of the colon. Then we start to see a smaller polyp. And by smaller polyp, we'd say anything less than 1 centimeter in size. But this could then develop into more of an intermediate polyp or late polyp, and then into more of an invasive adenocarcinoma. Moving through that adenoma or adenoma with a villus change to even dysplasia, low grade or high grade, before it changes into the typical adenocarcinoma. When we think about typical risk factors for colon cancer, well, we know being over the age of 50 is a risk factor. But we also know that things like lack of physical activity, use of alcohol and tobacco, and a low-fiber diet can contribute to colorectal cancer risk. But then there's also this personal history of inflammatory intestinal conditions or family history of colon cancer. So when we talk to patients about modifiable risk factors, obesity and being overweight is really at the top of the list. We can talk about a diet that's more Mediterranean-based and not a red meat-based or smoked meat-based diet, or even maybe a diet that's higher in sugar. We can talk about lower physical activity with our patients that can contribute to colorectal cancer. The use of tobacco, and of course alcohol consumption of greater than 7 alcoholic beverages per week has been linked with increasing tumor and cancer rates in men and women. The non-modifiable risk factors, again, aging. As we age, we see more cancer. And then there's that personal or family history of colorectal cancer or advanced polyps. And that's to include genetic syndromes linked with colorectal cancer. We have to think about Lynch syndrome. Race and ethnic background, as we'll get into as well. Diabetes is associated with an increased risk. Inflammatory bowel disease, our Crohn's and colitis patients, where we used to tell our patients with ulcerative colitis that 30% of them would have a lifetime incidence of colon cancer. And then also, not as frequently today, but a history of pelvic radiation therapy. So again, what about survival? Well, to reiterate, screening saves lives, and survival rates are now approaching 90% for those diagnosed with localized disease. Mortality rates have been declining by 53% from 1972 to 2016. And we really believe this is due to consistent increases in screening for colon cancer. Between 2003 and 2007, the Centers for Disease Control actually reported 66,000 fewer colorectal cancer diagnoses and 32,000 fewer deaths. And that's just an amazing figure. And we can relate it around that time, around 2003 to 4, colonoscopy became the screening tool of choice, overtaking the flexible sigmoidoscopy as the recommended test for screening for colon cancer. So again, our South Dakota screening rates, 65.6%. So not bad, but not up to our nationwide average. And again, 87,000 of our residents were not currently screened. And that screening occurred more frequently in women, people who were insured, people aged 65 to 75, and those who were insured by Medicare. Well, what are some of our targets for progress? Well, nationwide, we know 38 million Americans over the age of 50 are not getting recommended colorectal cancer screening. And only 2/3 of age-eligible Americans are up to date with their colorectal cancer screening. So, much like in South Dakota, adults aged 50 to 64 are the least likely to be screened. And these screening rates really vary geographically. So the highest rate, wow, look at Maine, 75.9% are being screened for colon cancer. But we look at New Mexico and 58.5% are being screened. So, what are some of our new screening updates to address these targets? Well, we know that for adults aged 50 to 75, we recommend screening for colorectal cancer. But the new big one is that in adults aged 45 to 49, we are now recommending screening for colorectal cancer in adults. And this was at first really suggested by our United States Preventative Service Task Force. And then we will be talking now also about adults aged 76 to 85 as well, and screening those individuals. So the American College of Gastroenterology has recently updated our guidelines, and back in 2018, guidelines were also switched by the American Cancer Society. So way back in 1995, the U.S. Preventative Service Task Force recommended that screening for colorectal cancer be in those adults aged 50 to 75. Coverage by Medicare for screening started around in 1998. Now in 2005, the American College of Gastroenterology recommended screening for African Americans to start at age 45. And then finally, speeding up to around 2018, A systemic analysis of evidence by the American Cancer Society Task Force actually recommended that colorectal cancer screening start at age 45, regardless of sex. And this was reiterated by the October 2020 statement that published an updated draft guideline to colorectal cancer screening. So if we look at colorectal cancer rising in our young individuals, we can see that there really has been an alarming rise in colorectal cancer in young adults under age 50. So I don't really think we can qualify colon cancer as an old person's disease. We also have to look at another target for progress. Just like many other diseases, 2020 was really a devastating year due to COVID-19 and affected colorectal cancer screening. So screening rates dropped by 86%. This year in the United States, there will be 18,000 young people under the age of 50 who will be diagnosed with colorectal cancer. And the cancers we're finding are on the left side of the colon and within the rectum. So these patients are presenting more so with rectal bleeding. We also know that these cancers, which are early onset, have a more aggressive histopathologic feature. And unfortunately, these patients have larger tumors and metastatic disease at presentation. Anecdotally, I can confirm that is what we are seeing at Avera Gastroenterology, that these younger individuals have bulky left-sided tumors and will come in with rectal bleeding. Unfortunately, patients under the age of 50 who are diagnosed with colorectal cancer may experience delays in diagnosis. The median time to diagnosis was 4 times longer in patients under 50 compared to those over 50, 217 days versus 30 days. Well, why? I think, we just don't think about colorectal cancer. You're under 50, let's not worry about it. We could say, oh, it's probably, hemorrhoids, some irritable bowel, just a little bit of rectal bleeding, constipation. Let's try to treat you with hemorrhoidal suppository. Let's try some fiber. And unfortunately, it can take an extended period of time to make this diagnosis or have the patient referred for colonoscopy. Now, the increases in early onset colorectal cancer is just not something seen here in the United States. We are seeing it in Europe, Asia, Australia, New Zealand, and Canada. And the majority of these cases are sporadic. It's really kind of fascinating to try to figure out why, and I think, of course, we're going to have more data coming out in the years ahead as to why. But there's been a really strong question if this could be related to diet. Is it due to a diet that's rich in red meat and processed meats? Is it due to high fructose corn syrup? Is it due to heavy alcohol consumption? Or is it not even diet? Could it be due to enhanced inflammation and effects on our microbiome? Perhaps even mirroring the increase in autoimmune disease? Or is it due to environmental toxins as well? So our updated 2021 guidelines suggest that we need to initiate colorectal cancer in average men and women at age 45, so no longer age 50, because of this incidence doubling of colorectal cancer in 20 to 49-year-olds. So the American Cancer Society, again, published that guideline lowering the disease. And so based on predictive modeling analysis and age cohort evidence, we've seen that, again, relative increase of 51% in colorectal cancer incidence in individuals younger than 50 between 1974 and 2013. And you can just kind of take a look that all ages are having a decrease in general in cancer, especially age 65. But boy, look at our age 50. If we look at right side, left side, and rectal cancers, we see this, unfortunately, this increase. So even though more younger people are getting colorectal cancer, thankfully it's still relatively rare if we look at cases of colorectal cancer per 100,000 people by age group. So we can see that uptick in 20 to 29-year-olds, 30 to 39-year-olds, and the 40 to 49-year-olds. But on the right side of the graph, look how low that incidence is compared to our 50, 59-year-olds, 60, 69-year-olds, as well as our more elderly population as well. But again, notice the trend is going down except for our younger patients. So what are the advantages of starting colon cancer screening at age 45? Well, we will have reduced colorectal cancer risk due to early detection of colorectal cancer in this group. And so over time, that detection and removal of polyps will really decrease the incidence of colorectal cancer in patients age 50 and over. And it's also a really desirable goal because of the societal impact of colorectal death at a very early age. The second area I'd like to focus on and the change in our guidelines is colorectal screening in elderly individuals. So we're now really seeing in general in our elderly population there's been gains in life expectancy, and we have this large increase in the geriatric population in general. So we know that the benefits of polypectomy are really delayed by 7 to 10 years after screening. But we know that colonoscopy and polypectomy really are of limited benefit if that patient is not expected to live at least 7 to 10 years. And as people age, we have that increase in competing causes of death in elderly. So our elderly may be at more risk with undergoing screening colon cancer compared to younger patients. Well, why so? Well, elderly may have more anxiety, there could be false positives, we could have unnecessary treatments, and of course, complications in this population group as well. So we would say from 76 to 85 years old, we would tell patients it would be time to stop colorectal cancer screening. And we have to really talk to our patients and all of us as you as primary care providers about that patient's overall health status. First of all, if that patient has never been screened, that would be a person who would be still at age 80 and never been screened. Let's not give up on him. Let's have him undergo a colonoscopy. But we have to make sure that patient is healthy enough to actually undergo treatment if that malignancy is found without limited life expectancy. And so you have to talk to that patient about their values and preferences. You know, I often joke that some patients actually get angry when I tell them we don't need to screen them anymore. They think, oh my gosh, doc, are you giving up on me? But now our guidelines, which suggest, well, hey, instead of just saying, okay, age 75 or so, we can extend that to even age 85. And it's pretty enlightening to see that people over age 75 who were screened for colorectal cancer had a 40% lower risk of dying from the disease. So let's not forget about our elderly population. So we're now saying let's have our young individuals, 45 and younger, and now let's talk to our geriatric 75 and older population as well. So if we think about screening tests, this has also changed as well. You know, the perfect colon cancer screening test would be non-invasive. It would be highly sensitive and specific. It would be safe, readily available, convenient, and inexpensive. And the American Gastroenterology College of Gastroenterology has described this in two ways. So there's a one-step and done approach or a two-step approach. So the one-step screening is really probably what we're all most familiar with, is that colonoscopy. We check on their chart, okay, age 50, send them off to GI or your local provider who is performing colonoscopies. However, there's plenty of us and other primary care providers who are doing a two-step approach, which is still great. But remembering that if it's positive, it's going to require a colonoscopy. And these limitations, again, if positive, requires a colonoscopy. So what makes a colonoscopy an important test? Well, it really allows for detection and the actual removal of polyps and the detection of early stage cancers all at once. So the pooled reduction in overall colorectal cancer incidence of 69% and the reduction of 68% in colorectal cancer mortality. Moving into our two-step screening test, a fecal occult blood test really has been replaced by a FIT test, and that's due to the higher sensitivity for colorectal cancer. A FIT test is very sensitive, 79%, and it's very specific at 94%. It's easy due to single collection compared to your fecal occult test times 3. And you're going to have a higher adherence due to no dietary or medication restrictions. Okay, there's none of the avoid red meat, don't take your iron, etc. And the overall colorectal cancer detection of about 80%. So again, what are the benefits? And I think we probably should all be moving away from your fecal occult blood test now. We know that it will directly measure human hemoglobin. So it's highly sensitive with one sample. It's very specific, even at a higher level of sensitivity. So you're going to have fewer false positive tests requiring definitive colon evaluation. And again, the diet, you don't have to adjust it, so you're going to have improved compliance. There's no need to adjust drug intake like NSAIDs or anticoagulants. Again, fewer false positives from the upper GI tract, so increased and improved specificity. And we can actually define a positive test can be matched to colonoscopy resources. And we can have this as a test to quantitatively value to stratify risk as well. And we can reduce the likelihood, again, that results are impacted by quality control issues in your lab. And it will also facilitate higher throughput. I mean, it's a population-based screening effort. So I think we all have really great reasons why now that the FIT test is much better than the conventional fecal occult blood test. There is a blood test for colorectal cancer screening. It's called a Septin 9, but you can look at the sensitivity. It's only 49% sensitive. It's specific, but this really would be for one who would refuse all of other colorectal cancer screening methods, and this is not an optimal test, so I hope none of us are using this exam. What about our DNA, our multi-targeted DNA test? Well, this is really another wonderful test that is out there now. This is 92% sensitive and 87% specific. And this is not a test you have to repeat every year. This is a test that we can use every 3 years. If it's positive and you have a negative colonoscopy, you repeat a colonoscopy in 10 years. So you need no additional testing with an EGD, a CT scan, or a colonoscopy. And that for some is probably the most challenging part about it, because you say, well, hey, the stool study was positive. How can the colonoscopy be negative? And we have to just remember that it's not a perfect test, and it decreases specificity with age. So again, an annual FIT and colonoscopy every 10 years were more effective, though, and less costly, though, than these targeted DNA tests every 3 years. Other screening tests, well, of course, back in the day, a flexible sigmoidoscopy was an option. And we could see direct visualization of the left side of the colon. But interestingly, a Norwegian study demonstrated there was no reduction in CRC incidence or mortality in women. So we've really kind of defined this as a declining study. It doesn't examine the whole colon. Patients often are not sedated. And then if you find an adenoma, you have to have that patient undergo a colonoscopy. So if you are sedating, then you're having that patient undergo sedation again. So really we should say a colonoscopy is far superior to a flexible sigmoidoscopy. And in the GI office, we're only using flexible sigmoidoscopies for follow-up perhaps of a polypectomy site or with a full colon prep and for follow-up of inflammatory bowel disease. There are a few other newer tests out there, the CT colonoscopy and capsule colonoscopy. So these are newer tests, and at Avera and Sanford, we definitely have CT colonoscopy. I don't think anyone in the state of South Dakota is doing capsule colonoscopy right now. There are some concerns for a detection of right-sided and flat polyps, and it's also operator dependent. A capsule colonoscopy could be and is approved for patients with incomplete colonoscopy and a lower GI bleed who's too high risk to undergo a colonoscopy. Both of these studies really depend on, again, like I said, local availability and reimbursement. And unfortunately, if both are positive, you're still going to require a follow-up diagnostic colonoscopy. Some patients prefer no sedation or will want to be on their way and not take the time off and have a whole day of work kind of erased by the time of a colonoscopy and sedation. So a CT colonoscopy may be an option. But again, it goes down to your radiologist and their comfort with reading CT colonoscopies. So again, that colon capsule, a good option for individuals unwilling to undergo any type of colonoscopy or a FIT study, but if negative, that screening can be repeated in 5 years. And this is just a really nice summary of performance characteristics for our colorectal cancer screening, from our stool and blood-based studies to our direct visualization studies as well. And really, I think most of us will be thinking colonoscopy with our detection rate of 100%. In addition, the cons of it, operator dependent, risk of bowel perforation, sedation, and complications of 4 to 8 and 10,000. But most of us are thinking of the FIT study and our DNA stool study as well, again with great sensitivity, specificity as well, with their major negatives again being that requiring that colonoscopy if positive. But our FIT study will be a yearly annual study, whereas our DNA will be really, the interval is truly unknown, but we're saying 3 years is what is proposed. And I think the other big thing with the DNA is the expense of it as well. Another interesting area that the American College of GI has recently updated and reiterated is that all African Americans should start colorectal screening at age 45, and efforts are really underway to try to improve detection in this ethnic group. So if we look at this group, we know that there's a 24% higher incidence of colorectal cancer in African American women and a 19% higher incidence in African American women. So we don't really know if the question is disparity due to lower screening rates or if it's a diagnostic follow-up and treatment issue. So special attention is being paid to the African American group. So again, 20% higher in African Americans. And again, our prior guidelines, even dating back to 2005, had recommended starting screening at age 45 in African Americans, with more emphasis on African American men. But now, again, everyone, men and women, age 45. When we look at Native American population, I really don't have any great data. And here we can look at the rate of new colorectal cancers in 2018, both sexes. Whites, 35.8 per 100, African American, 40.4. And our Native American Indian and Alaska Native, the number is actually lower at 25.7. So what about screening intervals in our average population? So again, we had said age 50, colonoscopy every 10 years, and now we're saying age 45 and moving along to a colonoscopy every 10 years as well. And we discussed the DNA test as well every 3 years, as well as our fecal occult blood test, which I would say less likely, or the FIT test yearly as well. What about those guidelines for family history of colorectal cancer? Well, guidelines now are stating that a colonoscopy should be every 5 years, beginning 10 years before the age of diagnosis, or age 40, whichever is earlier. And how do we define an advanced adenoma or cancer? So you would have an advanced adenoma in 2 first-degree relatives, or in 1 first-degree relative less than 60 years old. And again, both the colonoscopy and FIT and DNA study are all very suitable. So advanced adenoma is a polyp greater than 10 millimeters. It is a polyp with high-grade dysplasia. It is a polyp with any type of villous histology. And again, that risk will be much higher if that individual's relative is under the age of 60. And so when I'm doing my family history on my patients, I'm always trying to say, do you recall, was your mother or father, when they had that colonoscopy, did their screening start at age 50? And that can be important for us to risk stratify them as well. Another area of focus for our screening guidelines are quality indicators. And there are some big ones. We really want to look at cecal intubation rate, making sure the colonoscopist is getting all the way around the colon, at least in 95% of screening colons and 90% of all colons. We also want an adenoma detection rate of greater than 25 or equal to 25%. So in men, that's going to be greater than 30%, and in women, greater than 20%. Our here in South Dakota, and at least at Avera McKinnon, we definitely have seen a much higher adenoma detection rate. And I think in South Dakota in general, we find a lot of adenomas at initial screening colonoscopy. Our withdrawal time, greater than 6 minutes. And also we have to ensure that there is an adequate bowel preparation in greater than 85% of all colonoscopies. So if you're doing colonoscopy, within your note, you need to say if you were able to reach the cecum. You need to discuss your withdrawal time, and of course comment on that bowel preparation as well to ensure you are performing a quality endoscopy. So why do we care so much about quality indicators? Well, we first of all want to maximize cost effectiveness. These are very expensive procedures. We want to improve missed cancers. We see missed cancers, it happens, at a rate usually of about 1 per 3,174. And we also want to minimize risk to our patients. We want to decrease bleeding. A normal bleeding rate would be 8 per 10,000, perforation of 4 in 10,000. But also with colonoscopy, the risk would include an electrolyte imbalance, nephropathy, and cardiopulmonary events from sedation, and even splenic injury. So within quality control, we look at our colonoscopy quality like we discussed, and ways to optimize that with split dosing. We can help feedback and training to our fellow colleagues, multifaceted interventions, physician recommendation. But we can look at the quality of our fecal immunochemical testing with distribution, the way we're processing it, by looking at a single quantitative test, quick return, and a lab control as well. And then adherence to our colorectal cancer screening, making sure uptake of primary screening, uptake of a good diagnostic workup. And how can we do that? By removing financial barriers, active invitations, and again, patient navigation reminders. Something as simple as having the screening guidelines and reminders pop up on our desktop when we open up that patient's chart. Another interesting topic with colon cancer guidelines is actually the suggestion for use of low-dose aspirin. So if the age is between 50 and 60 with cardiovascular disease of greater than or equal to 10% over the next 10 years, and then you'd have to consider this in an individual who's not at an increased risk for bleeding. But the patient has to really be able to take that aspirin for at least 10 years to reduce the risk of colorectal cancer. And, just briefly, there have been multiple long-term studies suggesting the benefit of it to reduce incidence and mortality. But again, these are not patients, okay, you're going to get an effect in a year. It has to be really the benefit of 10 to 19 years after initiating the low-dose aspirin. And you could get up to a 40% reduction. And one of the most robust studies to show that was the Women's Health Study. However, not all studies have demonstrated this. This is Women's Health Initiative, where after following over 161,000 individuals, that we really didn't see a significant amount of decrease in polyps and colon cancer in those who used aspirin. Somewhat controversial, but still our American College of Gastroenterology does recommend a low-dose aspirin. And again, more studies supporting the use of low-dose aspirin, even if it's only 2 times per week, could lower the risk in men and women. And some of our final recommendations really go to the effect of having organized screening programs, which could be developed to help adhere to colorectal cancer screening and follow-up of a 2-stage screening if positive. The Flu Fit program is recommended by the American Cancer Society, and through the state of South Dakota, we can get information about that to help publicize that in our region as well. Other areas would be patient navigation, having a nurse who is assigned to patient navigation, patient reminders, clinical interventions, provider recommendations, and actually clinical decision support tools as well. The final recommendation, which I briefly discussed earlier too, is that really looking now at the multi-target stool DNA followed by a colonoscopy. Again, no findings should prompt no further workup, and to repeat that colon cancer screening at 10 years. So that is my discussion today. I would love to take some questions. Thanks for listening.